Hello and welcome to TiCME, Time Critical Medical Education. My name's Dr. Nick Taylor and I'm an emergency physician at the Canberra Hospital. This is Wolff Parkinson White syndrome. It's an area of particular interest of mine, so hopefully we'll be able to learn all about the basics but get into some of the meaty bits in treatment at the end as well. Okay, let's get started. So, Wolff Parkinson White is defined as a macro reentrant arrhythmia, i.e. there's a reentrant pathway that is occurring in a sort of large format across the heart. And the reentry occurs through this accessory pathway, which is known as the bundle of Kent. And it leads to pre-excitation of the ventricles. We'll talk about that in more detail in a minute. Patients are predisposed to tachyarrhythmias and sudden cardiac death, which is why WPW is something we care about. So those of you who've seen my tutorials before will notice this diagram. It's my smiley dog face version of the heart, atria, ventricles. You know that normally the sinus node tells the atria to depolarize and the signals get farmed through the AV node down the superhighways of the bundle branches. The ventricles depolarize, and this happens nice and quickly because of the bundles, and you have a narrow QRS. We've already mentioned that Wolff Parkinson White has an extra bit of conducting tissue, the bundle of Kent or accessory pathway. It provides a special bridge between the atria and the ventricles. So, during transmission, what happens is you still get a sinus node beat, it depolarizes the atria, but this accessory pathway is a bit special. It doesn't have really tight gap junctions and a long refractory period like the AV node, so it allows the signal to get through a bit quicker, and the ventricle starts depolarizing earlier than it does when it's depolarized via the AV node. So you get what is called pre-excitation of the ventricles. This is manifest on the ECG as a delta wave, which we'll talk about in more detail. The accessory pathway also provides a conduit for reentry, which I'll show in more detail again later. WPW is interesting diagnosis, and it was actually one of the first diagnoses where clinical medicine and electrophysiology melded together to come up with an accurate diagnosis. It was first described in 1930 by Wolff and Parkinson, all those guys, and it was written up in the American Heart Journal. And it was the first time that an electrophysiological accurate interpretation was made for a circus movement in the heart. Dara, the cardiologist from Holland, made the clinical sequelae connections afterwards. This is the front cover of the American Heart Journal with the original article, and it was described as a bundle branch block with a short PR interval in healthy young people prone to paroxysmal tachycardia. Given that it was written by, as you can see, Wolff and Parkinson and White, it's still lengthy, but it's probably easier to say than their original name. This ECG, although it's sort of a little bit fuzzy, is absolutely classic for a WPW patient with a short PR interval and a great big delta wave and a wide QRS. So who gets WPW? Well, the prevalence is around 2 to 4 per thousand people, and there's actually a significant number which are found incidentally in people who are asymptomatic. But symptomatic and asymptomatic patients are at risk of VF, and I guess that really does tell us that there is a role in ED for knowing a lot about rare conditions, because we do screen lots of ECGs every day, and there are a lot of people who get ECGs for their broken leg, for example, where we might be able to diagnose WPW. Up to half the patients who have VF did have no symptoms prior to their episode. That's important to remember. Alright, we've gone through a little bit of theory about WPW. Here's a nice soothing photo. This is down the south coast of New South Wales at a place called Mossy Point. I'm going to move on now. We're all soothed. How are we going to diagnose WPW? So, firstly, we can diagnose it in sinus rhythm. And the features we're looking out for are the short PR interval. Remember what I said? The connection, the accessory pathway allows the atrial depolarization wave to hit the ventricle early, therefore the P to R interval will be short. The delta wave is the pre-excitation of the ventricle, so the ventricle starts depolarizing earlier than it should. It starts from a place which isn't in the center of the ventricle and it's out a bit wider, so it takes longer to start depolarizing because it's not using the bundle, so it's a slurred upstroke. And because of this, you get a broad QRS complex. You commonly have a T-wave inversion. Now the broad QRS and the T-wave inversion often looks a little bit like a bundle branch block, because remember, a bundle branch block means that it's taking longer to depolarize the ventricle because the bundle isn't conducting properly. And you can have abnormal Q waves as well. You can make inferences as to where the accessory pathway is located by looking at the morphology of the pattern of the wide QRS. So it follows that if you have a left bundle branch type pattern, you've probably got an accessory pathway that's based on the right hand side, because it's taking longer to get across to the left ventricle, so it looks like a left bundle branch block. If you've got a right bundle branch block morphology, it's probably a left accessory pathway because it depolarizes the left ventricle first and takes longer to get across to the right ventricle. So to graphically illustrate this one more time, in sinus rhythm, you get the signal from the atrium, it hits the septum, it goes early down the accessory pathway and starts depolarizing the ventricle. Meanwhile, the rest of the signal goes through the AV node, down the bundles, and completes the depolarization. The early signal causes the delta wave, and the flow of depolarization across the ventricle leads to the bundle branch pattern with the wide QRS. Alright, here's some examples of ECGs of WPW in sinus rhythm. So if we have a look at this one, it's clearly sinus, but then we notice that the QRS complex is looking a tiny little bit broader than normal. It's a bit weird because we've got prominent R waves in the septal leads, which is abnormal. We normally have transition of the R to S ratio in V3, V4. We've got big R waves in V2, so we're thinking, ooh, this might be a slight right bundle branch block type of pattern. And then if we have a look, particularly laterally, it's often easier to see. We've got a PR interval that's short, and we've got a slurred upstroke. This one's probably the best single lead to look at it. Short PR, in fact, the start of the QRS is almost right on the P wave, and then we slur up. You notice we've also got some repolarization abnormality, this T-wave inversion, which is very common in WPW. So this is probably a left-sided accessory pathway. Here we go again with another WPW patient. Now this one you'd almost look at and go, wow, that's a very wide QRS. Is there a bundle branch block? Something like that. Is there an abnormal ventricle? Is that what we're dealing with? A severe RVH or something like that? So we need to carefully look at it. Again, we've got these great big R waves with an RSR prime complex in V1 that looks a bit right bundle branch blocky. We've got T-wave inversion. Remember, with our bundle branch block patterns, and whenever we've got abnormal conduction, we commonly get repolarization abnormality. And remember that the ST segments are commonly downsloping or upsloping, and the T waves are often asymmetrically inverted. So they're not classic parabolas. There's a significant asymmetry to the T waves, and the T waves are in the opposite direction to what the big QRS force is. So T wave inversion with big R waves. So we think, alright, there's something wrong here, but why isn't it just bog standard right bundle branch block or something like that? Again, if we look at our PR intervals here, particularly it's easier in the lateral leads, you'll find that this QRS is starting right on the back of this P wave. So P straight into the delta wave, slurred upstroke. So the slurred upstrokes can be concave or convex, and these ones here are convex. Okay, we're going to introduce a little bit of subtlety in our WPW diagnosis here. This is the ECG of a young healthy bloke who turned up in a tachyarrhythmia. He was cardioverted, and this was his rhythm afterwards. Now, young healthy people who have tachyarrhythmias, I really encourage you to look very hard at their ECGs once they're in sinus, because WPW, as I say, there is an incidence of VF. We do need to try and pick these guys up. So, what are the features here that could be Wolff Parkinson White, and are they very subtle? The answer is we don't have a great big wide QRS complex here. So we're thinking if there is a pathway that's accessory, it's probably going to be close to the AV node. There is a subtle hint that something's going wrong out here. There's these big R waves in V3, V4, and some fairly prominent ones in V2, so transitions occurring around here, which is a bit early. We've also got this subtle wideness, which is a little bit of delta wave going on. And if we actually look in lead 3, you'll see that where the P wave ends and the QRS starts is actually quite close together. So this guy actually went off for EP studies and was proven to have a paranodal accessory pathway which was successfully ablated. Alright, I've done a few ECGs in a row, a little bit of a break now. This is a photo from Canyonlands National Park in Utah in America. This is a lovely place to go. I got hit by this huge thunderstorm here just after I took this photo and ran back to the car getting pelted by hail. So we've diagnosed Wolff Parkinson White with some sinus rhythm ECGs. We're now going to look at Wolff Parkinson White diagnosis if someone presents in an arrhythmia. So you can have three main sorts of arrhythmia from WPW. The first is called orthodromic reentry tachycardias. Now these are a narrow complex atrioventricular reciprocating tachycardia. There is antidromic reentry tachycardias, and these are a wide complex atrioventricular reciprocating tachycardia, and then there are atrial rhythms conducted rapidly via the accessory pathway, and the most common and most dangerous of these is atrial fibrillation. Atrial fibrillation in Wolff Parkinson White is characterized by a very chaotic looking ECG, and there is beat to beat morphology variation of the QRS complexes, because it depends whether this beat has been conducted via the accessory pathway or mostly via the AV node or through a combination of both. We'll look at this in more detail. So back to the little schematics, remembering sinus rhythm through the AV node, through the accessory pathway, delta wave, wide QRS, short PR. Orthodromic AVRT. We get a signal that makes it through the AV node and then decides that due to the properties of the accessory pathway, it wants to turn around and come back, creating a macro reentrant circus type pattern, which then creates a narrow complex fast tachycardia. Now this is narrow because the signal is depolarizing the ventricles via the bundles via the AV node, and the accessory pathway is only conducting from ventricle to atria. This looks exactly or almost exactly like bog standard SVT, which is usually an AVNRT, AV nodal reentrant tachycardia. And the good news about this is not particularly dangerous because the signal's going like this. The scary way to get an arrhythmia in Wolff Parkinson White is antidromic. Anti meaning the opposite to normal conduction. So what happens here is the arrhythmia sets up by first going through the accessory pathway and then re-entering via the AV node. The downside of this is that this accessory pathway is not as safe as the AV node for conducting because it doesn't have tight gap junctions, and it doesn't have long refractory periods, and it's got a much more propensity to be able to rapidly transmit signals through it. So the speed of conduction through here is far greater than through the AV node, and the potential for instability is much worse. Because this arrhythmia is starting depolarizing the ventricles out here somewhere, not through the bundles, this is going to be a broad complex fast tachycardia. So narrow complex, broad complex. Okay, so here's a joke for all the orthopaedic surgeons listening to this talk. probably not a huge number, so I think I'm safe. What's pink and hard? An ECG. Very funny. We'll move on. Become a little bit of a fan of making sure we revisit information we've just learnt before we move on. So here's one more sinus rhythm ECG. Have a bit of a look at it for subtle signs of WPW. So again, it's a tricky one. Some of the signs that make us think conduction isn't entirely normal is that we've got this early transition to R wave dominance in V2, which is abnormal. So there's R waves in V2, V3 all the way out here. Normally they wouldn't start to V4. We've got Q waves, and if you remember, Q waves are a feature of Wolff Parkinson White. So this is a healthy young person. He's got some big Q waves in lead 3, makes us think, oh, what's going on? And we've got this subtle delta wave, best seen in the lateral leads again. So tiny little slurring here, tiny little bit of slurring, and with the eye of faith, this P wave just starts joining onto the start of that delta wave. This is a really tricky one. This guy presented with an antidromic AVRT, which is why I was very suspicious that these subtle changes were Wolff Parkinson White. Managed to convince someone in EP land that they should have a look at this guy, and again was found to have a paranodal left accessory pathway. Okay, so we're into arrhythmias. What have we got here? I'm not going to spend ages mapping this one out, but I think it'd be fair to say that this is regular. If we measure the QRS width, it does appear to be narrow. So we've got a narrow complex regular tachycardia, which a lot of us would say, well, that's probably just SVT. Well, that's not too unreasonable. Couple of little things I would like to point out. We've got these great big R waves here sitting in 2, 3 and AVF, which is pretty abnormal. We usually get a bit of S wave action down in 3 and AVF, and you see that there's big deep S waves in V2 and V3. There is a subtle left bundle kind of pattern here, although it's not wide enough, because we've got prominent R waves and we've got some deep S waves. That just makes us think maybe the conduction isn't entirely normal. There is really no sign of P wave. Now remember, we don't usually see P waves in any of the narrow complex SVTs. You could convince yourself possibly that there may be some little blips in here that might be retrograde P waves. But at the end of the day, this is a narrow complex regular tachycardia, with the only thing that may make you think about Wolff Parkinson White is this abnormal looking inferior leads. So this is an orthodromic AVRT, otherwise indistinguishable from AVNRT. Okay, another ECG, different to the last one. Why? It's wide, it's fast. Therefore, it's VT and we shock it, right? Well, maybe not so much. Let's have a better look at this and use a few little subtleties to help us. 29 years old, less common 29 to have VT. Done in the back of the ambulance, which is good, and he actually turned up with a blood pressure that was fine. And I'm just going to draw your attention to the rate. Remember, we get 10 seconds worth of ECG. So we count the QRS complexes. I've done it for you. There's 37 times 6. 222. Anyone ever seen VT at 222 beats per minute? Not me. It's usually peaks at around 190, 180. So that's a bit weird. We've got a broad complex fast rhythm with a young bloke who's stable and he's going 222 beats per minute. This is actually antidromic AVRT. Now, did I know this for sure when I saw this ECG? No. If we wanted to be really kind of particular, we don't see any fusion beats. We've got prominent R waves and deep S waves here, so we don't have concordance. I gave this guy some adenosine. He went back into sinus rhythm. I probably wouldn't suggest that that's your first line in people who you're not certain about, but I think that we'll talk about later if your confidence not an unreasonable way to go. Equally, shocking this person with some sedation would be absolutely fine and safe. So, broad complex, very fast, antidromic, atrioventricular reciprocating tachycardia. first impression when you look at this ECG is, what the heck is going on here? I like to look at my lead 2 when I start looking at ECGs because it helps me with my rhythm. It's just all over the shop. So let's just break this down, make it a bit easier for ourselves. Think straight away whether this is regular or irregular. It's definitely irregular. How many irregular fast rhythms do you know? Well, I know a couple. One's called VF. This isn't VF. One's called AF. And the other ones are extremely rare and we don't see them very often. So if we work on this being atrial fibrillation, how can atrial fibrillation look this bad? Let's think about this in the context of Wolff Parkinson White. So if we think about asymptomatic again, we've got the atria and the ventricle, and we've got this accessory pathway. Now in AF, the atria is chaotically depolarizing all over the shop. These chaotic signals are usually fed through the AV node, and the AV node's not stupid. It's got tight gap junctions, it's got refractory periods that say, hey, we're not going to take all of those, because if we take all of those signals and give them all to the ventricle, that's VF and we die. So we're pretty sensible here in the old AV node land. Trouble is, accessory pathway doesn't have all those limitations. He's a bit of a speed freak, and he's saying, you know what, I'm just going to take whatever you give me. Let's just feed it through. And so when the accessory pathway does this, we get these horrible looking broad QRS complexes going quite fast. So starting to depolarize the ventricle straight through the accessory pathway. Sometimes more of them make them through the AV node. We get some much more narrow looking, normal looking pathways. And then we get a couple of horrible looking beats again, followed by some which are a combination of both, where they've hit the AV node and the accessory pathway all at once, and then we go back into these ugly looking suckers again. So one of the things that I want you to just be absolutely sure about is it's extremely uncommon to have beat-to-beat morphology variation in a single lead in any other condition apart from Wolff Parkinson White. You really don't get intermittent bundle branch blocks, but if you do, every weird beat looks exactly the same. So if you had an intermittent bundle branch block, you would have a left bundle branch block, sinus, left bundle branch block, sinus, etc. Here, what we're getting is just every beat is different. Why? Because it's got two different ways it can get to the ventricle, can do whatever it likes, and it's just having fun. Trouble with this rhythm, very dangerous. Why? Because it can accelerate its conduction through that accessory pathway and end up making the person essentially have a polymorphic VT. I'm going to show you lots of these just for the pattern recognition. Again, irregular. One lead, 1, 2, 3, 4, 5, 6, or maybe 7 different beats. We can occasionally sneak in a P wave in the middle of all of this, but it's irregular, it's chaotic, there is beat to beat morphology variation. This is Wolff Parkinson White, pre-excited AF. You're getting the pattern now? It's fast, it's irregular, it's broad complex at times, and it is mostly here, and within one lead we have got multiple different QRS morphologies. It's ugly. There's not too many really ugly looking ECGs. Pre-excited atrial fibrillation is one of them. Alright, so we're a bit overwhelmed by pre-excited AF. I was a bit overwhelmed here. This is called the Landscape Arch in Arches National Park, and this was a horrendous storm. All of that sand about 5 seconds after this photo started whipping up into a mini tornado and hitting me in the eyes, and all of that hail and lightning started hitting, and I ran. A bit stupid really. Anyway, moving on. So hopefully we can recognize this thing called WPW. Question is now, how are we going to treat it? Firstly, someone who has never had symptoms and we just pick it up on an ECG. Well, treatment here is quite controversial. Most of the big studies come up with around the same numbers. The risk of a tachyarrhythmia for someone who's asymptomatic when diagnosed is about 8 to 15%, so let's call it 10% in any 5-year period. In one of the series, 19 of 180 people, so again about 10%, had significant arrhythmias. So we're talking about ones that are dangerous. And of those, 3 had cardiac arrest within 2 years. So although your 10% chance isn't everybody, you've got a sort of 15% chance, if you do get an arrhythmia, of having a cardiac arrest. That's tough if you're 19, isn't it? So what should we do? Well, we can help to try and risk stratify people with something called electrophysiology studies. And they are effective in risk stratification, and they can also ablate the accessory pathway in 95%. Now, you are more likely to develop arrhythmias if you have more than one accessory pathway, and if you have a short refractory period through that accessory pathway. So that's something which you're looking out for when you're doing the EP studies. But the kicker is that 3 great big EP studies have shown that there is a significant serious complication rate of doing the study in the first place. And that's between about 2% to up to about 4.5%. And these things are not benign little complications. They include perforating the heart, causing atrioventricular thrombuses that cause strokes later, not being able to cardiovert the arrhythmia you induce and dying of cardiac arrest. It's interesting stuff like that. So it isn't entirely simple to say everyone should have EP studies. Should we give people drug treatment when they are asymptomatic and we've diagnosed WPW? If you're going to think about it, the sort of drugs you might want to use are drugs which can slow down or stop conduction through the accessory pathway. Some of those might include beta blockers, type 1 sodium channel blockers, and type 3 blockers, which are also the potassium channel blockers, such as sotalol. Now, they can reduce the risk of getting AF, like the beta blocker component, and of the paroxysmal supraventricular tachycardias, but they do have side effects, and these are not, again, inconsequential. Sotalol, 3 to 4% risk of VT per year on long-term treatment. Amiodarone, probably about 2%. Flecainide, about 2 to 4% risk of VT. They make you feel a bit yucky. Some people get symptomatic in lots of other ways, erectile dysfunction, etc. They don't make your risk zero, and for a young, healthy, asymptomatic person, they're usually not tolerated and not complied with, and for a combination of those reasons, drug treatment is usually not recommended in the asymptomatic patient with WPW. So the summary of the person who's asymptomatic with their diagnosis is: get them along to a cardiologist who's got links to an EP physician. What they need to have is a very good and detailed risk-benefit discussion so they can make an informed choice about the chance of them going into an arrhythmia or potentially dying of their WPW versus the chance of them having a serious side effect from their EP studies. And I guess in some of the older group, the risk of being on treatment which may help to slightly reduce some of the arrhythmias. The evidence would suggest that if your EP studies show that you are high risk, you should attempt ablation. Okay, this is a pretty cool part of America. This is Bryce Canyon in Utah, and I was lucky enough to be there just after it snowed. So there's these big, gorgeous pinnacles of rock that have all been eroded away called hoodoos. So we've moved on from the asymptomatic patient, and now we're into the person who comes in because they've had symptoms. I've had syncope at home, or I've been dizzy a lot, or I present in my tachyarrhythmia. So let's talk about the emergency treatment of the AVRT. So what do we need to do? We need to either target the AV node or the accessory pathway to try and interrupt that re-entry circuit. Now, if we've got narrow complexes, and remember that's orthodromic AVRT, then we can manage this like you'd manage anyone with SVT, because if we interrupt the loop anywhere, it will stop the rhythm. So vagal maneuvers should be tried to try and just slow down the AV node conduction. You can give adenosine, which is fine, and second line treatment, as usual, can be a shock, give some flecainide, or even verapamil. This is safe if you're in narrow complex regular tachycardia. If you've got broad complexes, and this is antidromic AVRT, then managed depends on your confidence with your diagnosis. So if you're not certain this isn't VT, or you think, ooh, is it a bit irregular and is it pre-excited AF, then you shouldn't be going down the pathway of drug management like the orthodromic AVRT. But in almost all of the cases of antidromic AVRT, if you interrupt the pathway at the AV node or accessory pathway level, you will stop the arrhythmia. If you're not confident, then giving someone sedation and a DCCV is a very reasonable approach, and something which I recommend to most of my staff, that, you know, when in doubt, just deliver a shock, as long as you're someone who can confidently deliver the sedation as well. Okay, so this is the condition where we really need to be on our game. Pre-excited atrial fibrillation. Remember, we're going to diagnose it because of these morphology variation, chaotic rhythm. We're not going to call it AF with a bundle branch block and give it standard AF treatment. Why? Because if we block the AV node here, we can accelerate conduction through the accessory pathway. So if we're going 300 times a minute in the atria and we make the ventricle go 300 times a minute, we aren't going to look very good, and neither is our patient. So you need to try and target the accessory pathway and avoid the AV node. Now, recommendations from all the cardiology societies are to use, if you are feeling comfortable, if you want a sodium channel blocker, particularly procainamide. We don't have easy access to that in Australia. Personally, I've never given it. They also say you could use flecainide. It's not quite as safe. I don't feel very comfortable giving flecainide in these people. There is a association with WPW with LV defects as well, so I wouldn't like to use it. Abutolite is also possible, again, never used it. My drug of choice here is electricity, and of course if they're unstable, then shocking them is the way to go. So can't reiterate this enough, you don't want to give AV nodal blocking drugs at all to someone in pre-excited atrial fibrillation. Obviously, once you've got them out of this rhythm and you've got your diagnosis with your sinus rhythm ECG, there's really not much doubt that anyone who has WPW, who's had an arrhythmia, should go along and have EP studies. That risk-benefit ratio we were talking about in the asymptomatic people becomes more in the favour of doing the EP studies, so refer them all on. Take advice from your cardiologist about whether they should start on an antiarrhythmic drug like a sodium channel blocker prior to the EP studies or not. Okay, so I want to go through this particular case study. Now, it is one that has been published. It's in the Emergency Medicine Australasia from last year. It was a case I saw a few years ago. Story was, I got asked to see a patient in the ED. I was doing ICU at the time, and the person on the end of the phone said, "Oh, look, I've got SVT and it hasn't got better with adenosine. I'm just going to give it some verapamil. I can't remember the dose." I was a bit tired and I said, "Oh, you sure it's SVT?" "Oh yeah, I'm pretty sure." I don't like hearing pretty sure, so I said, "Look, don't give anything I wanted down. When I wanted down, this was the ECG. So we're going to look at it. What do you think? Are we good at our pattern recognition now? Look at lead 2, it's irregular. Look at any of the other leads. Do all of the beats look the same?" Answer, no. It's wide, it's irregular, with morphology variation in a lead. This is pre-excited atrial fibrillation. So, what should we do about it? Well, I said to this kid who was 19 and his mum, "Look, you need to be put to sleep and have a shock. That's the best thing to do." So we did that. And then this happened. This isn't making me feel very happy even now when I look at this. If you have a look over here, we've got shock 1, 70 joules, bingo. Ooh, very bad. what is this rhythm? People say, oh, it looks like torsades de pointe. Well, it's not torsades because he wasn't having a long QT at any point. I did ask a lot of people before I published this about what it is, and the consensus is probably just VF, not a polymorphic VT. So we shocked him into VF. Why did that happen? Well, before we get to why, I'll give you the good news. Good news is I had my thinking brain on, and we quickly just turned off the sync button. As you see, there's no arrows anymore, and gave him an unsynchronized 200 joule shock, and he went into this lovely rhythm called sinus, and he was completely fine. So after this happened, I asked myself, why did this guy go into VF? And when I looked at that rhythm strip, I noticed that there'd been a shock delivered on the T wave. Now, defibrillators aren't supposed to deliver R on Ts because that puts people into VF. I had a chat to the defibrillator companies and they said, no, we're not supposed to do that. What we do is we've got an algorithm that looks for R waves or S waves, and then we guarantee you that when it's synchronized, the defibrillator will deliver the shock within 0.04 milliseconds or something of recognizing this R wave. I thought, well, it's happened, so why will it happen in WPW particularly? So when I chat to the defibrillator companies, they do say that when the R waves are really close together, when someone's going really fast, then that time delay from recognizing to shocking can mean that it gets close to the T wave. Fair enough. But I thought there's more to it than that. And I did find out that the relative refractory period in Wolff Parkinson is actually prolonged versus the absolute refractory period. And the most dangerous time to deliver a shock or an extra bit of electricity to the heart is in its relative refractory period, which is the T wave upslope. Now, you've got more time in Wolff Parkinson White to hit that bit than you do in patients without it. The other thing is, in this chaotic QRS complex stuff in the pre-excited AF, the defibrillators have a bit of trouble finding R waves or S waves. And particularly in this patient, if you recall, there were S waves in the lead that the defibrillator was looking at, not R waves. So they struggle even more when we're looking at S waves. And the other thing is, because it was AF and he was young, I gave him 70 joules. We don't really know from any studies of external defibrillation. We only know from internal defibrillation during EP studies, but a low power internal shock is much more likely to cause an R on T if you hit on the upslope of the T wave than a big power shock. So, just to talk about this in a little bit more detail for you, this is the cardiac action potential. Phase 0, sodium channels. Phase 1, phase 2, calcium channels. Phase 3, potassium channels. The QRS matching that shows you that the big spike of the R wave follows this big fast opening of the sodium channels, and then you've got the S to T segment followed by the T wave. The absolute refractory period means that because these just depolarized, even if you whack a big stimulus on here, you can't make the ventricle depolarize it again. The relative refractory period is where a supramaximal stimulus can induce a new rhythm if it's in the right part. The upslope of the T wave is the most vulnerable port, and unfortunately people with WPW have a longer relative refractory period compared to their absolute refractory period, so the chance for hitting this is higher. So, to summarize what you should do when you are going to shock pre-excited AF to avoid an R on T. Use an R wave lead for your defibrillator. You can select usually between 3 leads for the defibrillator to look at. Use one where there's big R waves, not S waves. Time your shock so they're not going at 230 beats per minute when you press the button, but in a slower period if you can, because that means there'll be a bigger delay between the R wave occurring, the T wave, the next R wave. Start with a higher power. My suggestion is at least 120 joules, if not just using 200. And print out a strip from your defibrillator and check that those little arrows are actually pointing to R waves. In our patient, just before the shock, the R wave started being missed and the arrow started falling on the upside of the T wave. So that's my advice for trying to avoid VF if you are shocking pre-excited AF. And if you want to read the paper, you can see it in Emergency Medicine Australasia from December 2013. Okay, another bit of science out of the way. This is the Blackcomb Glacier at Whistler Blackcomb, and this is the big ridge which gets less steep as you go that way, and everyone stands here and peers over the edge trying to get up the nerve to drop off. Okay, so this is a second case to try and reiterate what we've talked about. Do you remember this one? 29-year-old bloke, broad, complex, regular rhythm. So we decided it wasn't VT. Do you remember what sort of AVRT that is? It's broad complex, so it's an antidromic AVRT. So treatment decision here is, how do we get him out of this rhythm? Remember, if you're comfortable this is the diagnosis, you can treat this like an orthodromic AVRT. You can try adenosine. If you're not feeling comfortable with that, you can just shock it. So probably wouldn't give it verapamil, that would be my advice, but I would be happy with a single dose of adenosine. When I do that, I usually have them in the resus bay with the defibrillator pads on, just in case. Okay, third case, haven't seen this one before. This is basically a bit of extension, so we're going to get a little bit technical. You can turn off now if you want, but simply broad, complex, or narrow. It's narrow, regular, irregular. It's regular. Do you see P waves? Not really. Okay, so it's a narrow, fast, regular tachycardia. Happy if you call it SVT. Happy if you give it adenosine. Adenosine will work. Here's the extension bit. When we have a AV nodal reentrant tachycardia, if you remember from the tachyarrhythmia talk, you do get P waves because that circus movement in the AV node gives an echo back to the atria. But because it's happening all here, that P wave is getting buried in the QRS complex and you never see it. Remember, in Wolff Parkinson White, you've got an accessory pathway. It might be out here somewhere, and our rhythm is going like this. So the time from when the ventricle depolarizes to this atrial echo appearing is a bit longer. So what you get is the QRS complex followed by a small P wave. Now the P wave does not occur after the T wave, so it's not sinus. This is the R to P distance we're talking about, if you remember from the previous tachyarrhythmia talk, not the P to R distance. So what we've got to look for is things that might be little P waves occurring after the QRS. And if you look very carefully, you'll see here in lead 2, there's this little blip that's happening before the T wave. If you look up in V1, there's this tiny little blip that's happening after the S wave. These are called pseudo, for not real, R primes. So second R wave, pseudo R prime, and pseudo S prime waves. When you see these are actually P waves, and this is telling us that the R to P distance is a bit longer than in AVNRT. This makes it a little bit more likely that this is a orthodromic AVRT. You don't need to worry about that, that's just a subtlety, but what can you do with this person? You can treat them with adenosine, they should get better. So let's summarize treatment for people who are symptomatic of Wolff Parkinson White. If it's narrow, treat it as per a usual SVT treatment. If it's wide or pre-excited AF, give them a shock. All of them need to go to EP study because they've all been symptomatic. If they've had orthodromic AVRT, it's not urgent. If they've had pre-excited AF, you really should try and get these people in pretty soon. Medical treatment can reduce your risk of arrhythmia, but young people hate the side effects. For AVRT, beta blockers, flecainide, sotalol, propafenone are okay. And these are most commonly used in those who've also got congenital heart disease, because there's a big association with WPW and congenital heart disease, because it's sometimes almost impossible to do EP studies and ablation in people with congenital heart disease. Most of the young people with symptomatic WPW end up going for EP and hopefully getting a successful ablation as their primary treatment. Alright, so we've covered Wolff Parkinson White today. I hope that's a good overview for you. I hope it gives you some tips for recognising the dangerous rhythms and then for treating them. Particularly want you to remember the tips on when you're cardioverting people. You can send questions to me via this website. I'll see you next time. Thank you.